Continuing on, we're going to take a look at the last part, which is the treatment, exercise guidelines, and the summary. Treatment options are in relation to the client's body mass index. And you can see that when somebody has a BMI greater than 30, that is in the center. Pharmacological or medication and healthy eating, physical activity, and behavioral therapy are going to be part of the treatment. When someone is over 35 with complications, then surgery might be an option or a recommendation. If somebody is over 40, greater than or equal to 40 with a BMI, then they are a candidate for surgery. And I will say that if somebody has a complication, they have health complications, and they're less than 35, surgery still might be an option. So this is just a stepwise way of looking at it, that the first step is always eating, activity, and behavioral changes, and we don't jump to medications until somebody is farther up the chain. As you know, if somebody has no symptoms and they are wanting to start low to moderate exercise intensity, then an exercise test is most likely unnecessary. And if but an overweight, obese individual is at risk for other comorbidities associated with cardiovascular risk. So if they do have comorbidities, they may be on medications, they may have some limitations for movement, and we have to think about that for the exercise test. So medications, especially if they have a cardiovascular disease, we're thinking about the timing and the type of medication that they're having, such as a beta blocker. We also have to look at their increased risk for diabetes, and for anti-diabetic medications, the timing and the location of where, if they are on insulin, needs to be considered. For equipment, the exercise equipment must be able to meet the weight specifications, and they also might need to be adjusted for comfort level, because someone has most likely has a low exercise capacity. You might have to start with a very low exercise level and have small increments, which might require you to use an arm or a bicycle ergometer. So in that case, we would have the capacity to have more lower intensity exercise and be able to make smaller adjustments. Also need to make sure that you have a proper blood pressure cuff that does fit the individual. You don't want one that's too big or too large ever, but especially in this case, you want to make sure that your blood pressure equipment is appropriately sized. So the cycle with a ramp or a stage protocol might be necessary depending on a person's current level of physical activity. And if you do use a treadmill, you're going to potentially be using a much lower MET progression. And this is especially for individuals that are highly physically inactive and also on the morbidly obese level. We have our standard stopping points, as well as the person failure of equipment, failure of the or request to stop, right? So those are just some example stopping points. The exercise recommendation is ultimately goal of an aerobic equal to or more than 5 days per week, and starting at a moderate intensity and then progressing as a person becomes as they become more fit and they become acclimated. Our goal is to work to 30 minutes or our recommendation of 150 minutes per week. But in some cases, as I'll mention in a few minutes, more might be needed. And the type of activities are going to be, you can be kind of creative. Walking, cycling, swimming, group exercise. It needs to be something that a person feels comfortable and is able to have self-efficacy, that they're willing to, that they have the capacity, the belief that they can, and something that they enjoy. Resistance training, we're looking at 2 to 3 days per week, 2 to 4 sets, a little bit more, and with flexibility, standard recommendations. So the special considerations are that we have to focus on a goal of 30 minutes, but we might not be able to do that initially because of the increased level of fatigue and also the low level of fitness that a person has. And so small chunks, frequent chunks might be appropriate. And this is to be able to, once somebody has lost their weight, we're looking at 2,000 kcals per week, or 250 minutes per week of exercise. And in some cases, a person might need to, if they do have to go more than 250, it should be spread out between 5 to 7 days per week. We can accumulate them, but focus on bouts of 10 minutes or more. And intermittent exercise is certainly something that might prove to be encouraging exercise adherence. And so chunks throughout the day might be more doable compared to 30 minutes. For resistance training, an individual just doing resistance training is not going to get a big weight loss. And when somebody is doing a resistance training program, it doesn't necessarily mean that they will not lose fat-free mass or have a decrease in resting energy expenditure. We know that as a person loses mass, that there's less need for the fat-free mass to sustain a person moving, so you are going to have a decline in fat-free mass. There are potential other health benefits, and that could be like improvements in your cardiovascular disease risk, improvements in your diabetes disease risk, improvement in arthritis, improvement in tendinitis, improvement in pain. So there are additional health benefits that are possible. Training considerations, I guess I'm going to say this about 5 ways. For individuals that don't respond, they might need medications or surgery. But our goal is to try to focus for goal setting 3 to 10% over 3 to 6 months. And this is a slow but sure way of doing it. 500 to 1,000 calories decrease per day is going to get us to our target of 1 to 2 pounds per week. And you might have to be more aggressive as you get closer to that 10% loss. Individuals with a medically indicated very low calorie diet of less than 1,500 calories, these might be possible for individuals, for select individuals for short periods of time, and they will result in some pretty quick weight loss but it's not a long-term solution. These plans need to, whatever we do, we want to incorporate a lot of communication, utilize registered dietitians, and make sure that we stay in touch as people do lose their weight, that they have support to maintain that weight loss. Now, the American College of Sports Medicine has a position stand on physical activity and weight loss, and the search of the literature indicates that there might be might take more than 150 minutes per week or 30 minutes per day on 30 minutes of physical activity on most days of the week, and that we have minimal weight loss if we just get to the recommendation, modest versus more significant weight loss over time. So what we know is that we want to get to this dose response. The more seems to be about better, and there appears to be that some evidence supports that after somebody does lose their weight, that preventing the weight gain, that you might need a significant amount of exercise, and that is maybe 200 to 300 minutes per week, or 30 minutes on most days of the week. So that's kind of what we're looking at. There's no specific recommendation, but it's thought that more is better. There are some medications that are FDA approved, and they have really 3 different ways. One is to reduce appetite. The second is to impair absorption of calories. And the third is to increase energy expenditure. So reduce intake, reduce absorption, or increase energy expenditure. And those are our 3 classification of drugs. I won't ask you about specific ones unless I, about the impact on exercise, but they're all pretty interesting. There's a couple of them that are over the counter. I think Ally's over the counter, and that one, if it's a higher dosage, then it has to be prescription. Finally, if somebody has a BMI greater than 40, they are a candidate for one of the types of bariatric surgery, and there's really four surgeries: bypass, banding, biliopancreatic diversion with duodenal switch, and a gastric sleeve. I've got a picture of 3 of them. The biliopancreatic diversion is actually 2 surgeries. And there are guidelines of who is going to be able to have this, and there are exclusion criteria. And if somebody has, if they're abusing drugs or alcohol, they can't participate. If they really have to demonstrate that they can adhere to the postoperative care by losing some weight before they have the surgery. They can't be mentally have an uncontrolled or severe psychiatric illness, and there's just quite a bit of criteria, and you have quite a bit of an analysis to make sure that you're capable of doing it. So candidates for surgery really need to be evaluated extensively. The Roux-en-Y, you can see that the stomach is disconnected, and so there's a large part of the, or not, the stomach's disconnected. The stomach is greatly shortened, and a lot of the small intestine is shortened as well, and so you lose a lot of absorption area and a lot of capacity to consume calories. The sleeve gastrectomy is removing a large portion of the stomach and stapling, stomach staples, and the band is inflatable. There's a port, and it decreases the size of, or the passing of food into the stomach, slows it down, and that gives a sense of fullness much more quickly. Here's another picture of that Roux-en-Y. This is from an article that I thought had a nice summary or figure about the factors that are associated with long-term weight loss for the greater population of individuals, obese individuals attaining non-surgical weight loss programs or have participated in non-surgical weight loss programs. So there's a number of steps or a number of ways that can paths that can assist. Eating breakfast regularly, getting enough sleep, that would be on there too. Long-term self-help groups, that's sort of people that will maintain their contact with their clinician. Having their depression under control, being physically active, those are key points that help with weight maintenance. The metabolic syndrome is characterized by clusters of some risk factors that are increasing your risk of cardiovascular disease, diabetes mellitus, and stroke. And it involves with inability to regulate blood glucose, inability to maintain normal blood pressure, poor blood lipids, and also obesity, central obesity, which is measured by waist circumference. So if somebody has at least 3 of these, they are at risk for or characterized as having metabolic syndrome. I want to also mention that for the hyperglycemia, elevated blood pressure, or dyslipidemia, it's either having these 3 or being on medication to control the abnormality. So a person could be on hypertensive medications, on lipid medications, or diabetic medications. The criteria is listed in table 9.2, and you'll see instead of just saying obesity, it's central obesity. So it is waist, the waist circumference is a value, and you'll see the waist to hip ratio is another value, but just the pure waist, depending on which organization that is utilized. Insulin resistance does not, it is interesting, it's greater than 100, or you can see previously diagnosed as type 2 diabetes. Dyslipidemia has to do with your HDL and your triglycerides, and the HDL numbers are 40 and 50 for men and women, where you'll see for who it's 35 and 39, so it's a little bit more forgiving for the World Health Organization. For hypertension, greater than 130 or 85, and other is only because there's an additional category for World Health Organization, and that is having some renal failure, or actually the albumin excretion rate. That's something that has to do with the liver. The International Diabetes Federation guidelines are focused on 5 to 10% weight loss within a year, moderate increases in physical activity, and changes in dietary intake. The presence of metabolic syndrome does not result in the requirement for exercise testing, just as the diagnosis. If somebody is going to start low to moderate intensity exercise, so there's no requirement for that. Now, if an exercise test is needed, if they have symptoms, for example, then the general recommendations can be followed, but we're going to pay close attention to lipid, hypertension, or hyperglycemia assessments for the individual. Many individuals with metabolic syndrome might need to have the same considerations for exercise protocols or equipment, and as the individual who has obesity or is overweight. They probably will have a low exercise capacity, and in that case, small increments of the exercise protocol, exercise testing protocol, will need to be followed. And we definitely are going to be taking our blood pressure measurements before, at every stage, immediately at the end of the test, and every 2 minutes after. So strict adherence to that is required. When you develop the exercise program for someone with metabolic syndrome, we have to look at each factor. And so, for example, if somebody has, if they're pre-diabetic, then we're going to look at diabetes. We're going to be very careful and look at the criteria for exercise programming for diabetes. If somebody has arthritis and metabolic syndrome, we're going to look at any kind of limitations that a person that needs to be considered for arthritis. And our goal is to start very moderate, goal of getting at least 150 minutes per week, and focus on getting a goal at 5 days at 30 minutes per day. And if we can, we're going to look at moving to a more vigorous intensity to decrease those factors of metabolic syndrome. For exercise prescription and special considerations, after someone is or looking at body weight is probably going to be a real key component. And this again is a potential for more than 150, but we're looking at 250 to 300 minutes per week over 5 to 7 days per week. We can start out with smaller chunks of 10 minutes or more. And let's see here. In this case, resistance anaerobic training can be very effective on decreasing the risk or prevalence of metabolic syndrome than if we just did aerobic alone. So adding resistance exercise can be really good, and if we do it more than 2 to 3 days per week, it really impacts those factors that are the criteria about metabolic syndrome. And that is all I'm going to give you about this today. I hope that this has been informative. There's a lot of overlap between obesity and metabolic syndrome. Just a little bit in terms of weight loss being the biggest factor, increased physical activity, but that might need to be spread out over more days, and resistance training alone is not going to be impactful, but the combination appears to be impactful.